I'm Megan Haupt. I'm Chief of Staff with the National Association of State Mental Health Program Directors. Again, I'm very excited that Jennifer Corbin and Lieutenant Steve Thomas are joining us today about co-response and safe stations in Anne Arundel County in Maryland, episode 172. And just to let you know, this is the registration page for the Crisis Jam. For those of you watching this by YouTube, this is where you would go to see, to register. Remember, you need a Zoom account. There'll be authentication for that. You can see past episodes. You can see feature presentations, quotes, past trivia, crisis trivia, hot seats. So great for that. We've had 400 unique speakers, almost 500, I hear. So if you have any ideas on speakers, let us know that. Look at all those names, and we have even more. This is really cool because SAMHSA put out a partner toolkit in terms that has social media messaging, some marketing in there. And this is a recent picture that they, photo that they just included, and it's ways to access LGBTQI and services and resources, text, call, and chat. So just really thrilled for that addition. This is 911 meets 988 at emergency call center serving Gig Harbor area. This is an article that just came out. This is our latest crisis news. It's a place in Tacoma, Washington, where they have built where 911 and 988 are together. And so the intention there is to move away from first responders and toward mental health professionals. It's first of its kind. This is an article actually brought to us by our colleague Ted Lutterman. He's with the Nashville Research Institute. It's a simple way to make the suicide hotline more effective, and it's really about routing. When people have area codes that don't necessarily match their location, it's really about having the call answered by the location of where the nearest cell tower is, otherwise known as geo-routing. So this is an article about the bills related to that. Okay. And this is the National Summit on Stigma. It's in Salt Lake City, Utah. June 24th through the 26th in 2024 at the Grand America Hotel. It is open. So if you're interested in that, there'll be more information. And I believe the Crisis Jam folks are putting that in the chat. All right. We're now going to do the Crisis Trivia Hot Seat. This is audience involved. I love the audience involved because then we all get to think together and then we'll see if we're right. And if we're wrong, it'll help us think. So this is, remember to put your response in the poll and not in the chat. So the co-response model began as a response to the recognition of the limitations and challenges faced by law enforcement in dealing with mental health related calls. All right. So the co-response model, there we go. Wait a minute. I have my little poll next to me here. Okay, the co-response model began as a response to the recognition of the limitations and challenges faced by law enforcement in dealing with mental health related calls. What is the primary goal of the co-response model in behavioral health emergency services? A, to minimize response times. B, to provide medical care. C, to reduce the need for police intervention, or D, to increase community engagement. Please put your answer in the poll. All right. So we're going to wait for about 50% response. Oh my goodness, look at that. I think we think we see the obvious, to reduce the need for police intervention. 79% of you put that. That is the prevailing response. And let's see what the actual answer is. Yes. Well, let's talk about this one. This is interesting. So the co-response model reduces police intervention by involving mental health professionals alongside law enforcement officers. It offers specialized assistance, appropriate referrals, preventative measures, community engagement, and training and awareness. So way to go, audience. Fantastic. Now, interestingly, this leads us to our feature presentation. Jennifer Corbin and Lieutenant Steve Thomas. Jennifer Corbin is Director of the Anne Arundel County Crisis Response System, and Lieutenant Steve Thomas is CIT and Peer Support Coordinator for Anne Arundel County Police. Now, they may have a different perspective on that trivia question. Their model does something a little bit different in co-response. So the Crisis Jam is all about opening our minds and looking at things from different perspectives and getting ideas from communities. So let's go to them and go for it. Thank you so much for being here. And just go ahead.
Thank you.
There you go.
Okay. So thank you so much. Just real quick, I'm Jen Corbin. I'm a licensed social worker here in Anne Arundel County, Maryland, and as we said, the Director of Crisis Response.
And I'm Steve Thomas. I'm a lieutenant with the Anne Arundel County Police who thinks he's a social worker and wants to be a social worker.
So we're super excited to be here today. I think the question leads right into the conversation. I do want to start by saying our crisis system here in Anne Arundel County is rather robust, and that we do have the mobile crisis system where we have the paired licensed clinicians responding to calls for police and to the community through our warm line. We have a very robust 24-hour warm line that people in the community can call in and actually ask for a mobile team. So they don't necessarily have to go through 911 for that, but our officers are able to raise us on police radio and have us respond. So our clinicians do carry police radio as well. I want to say that to lead into the piece that we're here to talk about today, which is our co-responder model, which is also held at our crisis response location. So where our warm line, our 24-hour warm line is, our mobile crisis is, we also have what we call our co-responder model is called the CIT team, a crisis intervention team. And basically we pair an officer with a clinician to go out on calls for many different reasons. I love the clip that we showed at the very beginning. I think they were spot on the reasons for running co-responder, the time that it takes for a mobile team to get there, that law enforcement is left kind of on scene, dealing with things, as well as just showing the partnership upon arriving as a co-responder model is huge. The one thing I want to say in starting this out today is that there's two key pieces to this. When we look at that question, Steve and I answered it with D, because our ultimate hope is that we increase in community engagement and that we build back a trust for police to be on scene and to be seen as helpful and not hurtful. Though we actually know the goal is to reduce police intervention. I don't always want to reduce police intervention. And that's kind of what I hope you can take out of this today, that there is a benefit many a times to have a special trained officer on scene for those calls for service. Second piece I want to just share is that within our crisis system, it is not about putting the social worker or the counselor in the police department. We put the police department into the crisis system. It's a model in which I really, really believe in. It is a piece that I think is super important because it shows the officer how to continue to keep their skills up on the CIT side, on the crisis intervention side. And it also allows us to work throughout the crisis system using the partnership. That means sometimes an officer can get on the phone on the warm line and help answer questions for someone. It could be that mobile crisis doesn't want to take law enforcement out with them, but a patrol officer, but rather a CIT officer. One of the pieces we work really hard here is to reduce that stigma piece. So our officers in-house are in a softer uniform in an unmarked car.
And when we started this in 2014, one of the first things Jen had us do was Jen and I trained the entire police department in mental health first aid. So everyone has that basic level. Side effect, we had a 21% reduction in use of forces. We have voluntarily trained 28% of our department. And what I mean by that is in the CIT model, we do the 40-hour CIT training. Officers voluntarily attend the training, and we're up to 28%. What we're doing is changing the expectation of officers. And when you hear the national trend of saying keep police away, it's actually given the expectation that officers fulfill that I can't be helpful. We're doing the opposite. We're training officers. Officers want advanced training. We're giving them the advanced training to allow them to be helpful to people in crisis. And the expectation, and we give the expectation that you are going to be helpful to someone. And if you need additional resources, we are here to supplement that with the resources. It also allows us to work in other areas of the community that crisis normally doesn't assist. We're able to decriminalize working with judges, state's attorney, public defenders that help people to decriminalize behavior when someone's in crisis so that they are getting help and we're not hurting them.
And a lot of this is seen through partnerships we developed through our Safe Station program. As you saw at the beginning, it was about the co-responder model and Safe Station program. Safe Stations is a program that we implemented with the partnership of our police department, fire department, our emergency rooms, our health department, and our state's attorney to address our opioid epidemic that we were having here in the county back in 2017. And what we did is we opened up every fire and police station in the county to be a place where someone struggling with any type of substance use could come, and they would call the warm line and we would dispatch out to get them the treatment they need. A lot of what we do since then, because we've been pretty successful, over 5,000 assessments, we have a 70% success rate in connecting people to treatment and a 50% success rate of people staying sober plus 60 to 90 days, if not longer. Within this model, the reason I share it is what I didn't expect to happen was how the co-responder model would impact our community and really change the thinking of our programs. And what I mean by that is it was the officers taking people to the stabilization centers. It was the officers taking them to treatment. What was interesting was as time went on, and we do a lot of follow-up in our CIT. I would say our CIT team does more follow-up than initial dispatch. In that, what we didn't realize was going to happen is that the clients or consumers were going to connect so well with the officers. And that's how, when Steve talks about linking to the judicial side, is that they started to ask the officer they were connected to go to court with them, or to go and speak on their behalf on how well they were doing, to take them to pretrial and probation if they were dealing with consequences of their substance use. And so while that's a small piece of our crisis system, it's been a huge impact because, as you see, we've had 50% of the people who come through be able to maintain a good amount of sobriety. And when they can't, it's okay. We're there to kind of help them navigate the system again. But I think as a social worker, when I was setting this program up, I was doing it on the person-centered model instead of kind of going to the hospital and telling them what they're going to do, or telling them this is the model they must go to because you need withdrawal management, you need inpatient. We allowed them to come to the police or fire station when they were ready and kind of tell us what they wanted. And from that, the effect has been, we don't really use the fire and police stations much anymore. We're so successful that we're meeting people in the community, that the word has gotten out through our peers and through our care coordinators that, this is a system you can trust, and you can now just call in and ask for help. But that was done through a co-responder model along with fire and police. And we've seen a great success. And I just kind of wanted to share that as a piece to what we do in the co-responder model, as well as I know there's a lot of talk around drop-off centers for police officers to take people instead of the hospital. We do it a little differently here. We go out and assess the situation. We don't have drop-off centers, but we have some stabilization and walk-in centers that we can utilize as long as someone's not a danger to themselves or others. An officer will take them there and make sure they get checked in and get the help they need. In our county and really in the state right now of Maryland, we are still working towards if someone needs to be emergency petitioned for us, is a danger to themselves or others, they still have to go to the emergency room to be evaluated. So this is a little bit lower risk that we are working with. But the key here is just the partnership that we've been able to develop through our crisis system.
And what Jen didn't say, though, is when we started Safe Station, it was strictly just to keep people alive. The epidemic was that bad, but now we're able to change lives, and we become, as officers, the social supports. We've actually been able to work it with our judges, and this shows how it's a whole community team together, where if someone does have a warrant and is prohibiting them from getting in treatment, we take them to the courthouse, unhandcuffed through the front door before a judge, who the judge will then recall the warrant and release them back, and really with the encouragement and that expectation that they are going to complete treatment, the expectation that their life is going to be changed. And that's where we have had the greatest success.
And another, and so that's just kind of one piece of what we do in regards to our co-responder model. I think the unique piece, and we saw that in the video at the beginning, is what we can do to be supportive. It's that follow-up care. I love in that piece that they were talking about, and I believe it was Nashville or where the program was that was doing the co-responder model. They talked about the key is not the actual call for service. It's what we can do to follow up and be supportive throughout. And what we have found in our people that we're working with is that the follow-up is the key, right? We reduce the crisis rate at the point in time, and we can be there together, clinician, officer, peer, whatever kind of team it's made up of. But it's that follow-up to show them that we're continuing to support and to fill gaps for them and help them in any way possible. One of the keys to doing this is that if the person goes back into crisis, they have several options and resources available to them to reach out for help. And hopefully we don't get to that extreme crisis level that we were at before, as well as just kind of supporting our community on a day-to-day basis.
And the biggest compliment we receive is when people that we've helped give back to us. We're running a CIT training this week, and two of our presenters are people with lived experience who we helped when they were in crisis. And they're given back by teaching our officers and officers from other jurisdictions their life experience. One, Melissa Owens was the CIT International Person with Lived Experience of the Year last year, where she shares that her presentation is Patient, Not Prisoner, How CIT Saved My Life. And it's how officers got her to the hospital instead of arresting her. And then how, as a CIT unit, we followed up with her, taking her to her doctor's appointments, having that bond with her, that we are the ones that became the social support, working with her family, maintaining or getting her to a point of stability where she's back in the classroom as a thriving, great public school teacher.
And she does teach at CIT International at the program each year and is really sharing her story. So you can look it up. She's really putting herself out there because she wants to show the difference it can make on two counts, right? Mental health, and that you can be successful in life and have mental health issues and get help, and also to show that when you are struggling, she gives really good ways to set up a plan of care using the police as maybe one of those in her plan. So it's just something, if you want to look up, it's called Patient Not Prisoner. And I thought I saw something about a question. I don't know if you're holding those or if we should pause for questions now, or.
We will get to those because there are
Okay.
many, right? There are a lot of different perspectives.
Yeah.
It's
Yeah, and I
fun.
think our
Yeah.
hope here today is just to get people thinking, not saying this is the right model for everyone, not saying we're a, I guess you'd call it medium jurisdiction. But the hope is just, my goal in talking with individuals that we serve, and we have a lot of people with lived experience who work in our crisis system here. We don't call them peers. We actually look at it a little different here, but the goal here is to just start thinking back to how do we pull in our law enforcement, because they are at times going to be first on scene. They are going to need that intervention. There's going to be that piece where we're going to have to share the space on a call for service, and how can we work and be better partners. And we extend that out to fire as well. So both police and fire, we do a lot of training. But I think the goal today is just to share our model. It might not be for everyone. Like I said, smaller jurisdictions may have to do things differently, but if there's something you can take away from this, that's the hope, is just to start sharing that space of conversation between the counseling world, the lived experience world, and law enforcement.
And the final thing for me is that when Jen created the system, we started providing peer support to officers, and that's where the empathy comes from. We as police live in the community. We have the same challenges as every other community member with our friends and loved ones. And as we help, we take care of our own mental health, from the trauma that we experience as first responders, all the way through other traditional mental health crises that our loved ones have. That's where officers really gain empathy for the community, because they recognize is I'm part of the community, my family's part of the community. And again, how can we be helpful and not be hurtful to our friends in the community?
And I think, just to wrap it up, the piece that he just said that just hit back to me, we just did a big training with all of our judges in the state of Maryland. One of the things I was shocked that sometimes is forgotten is that when people are in crisis, no matter who you are, there's an anxiety piece to it. And when we were teaching the judges, I said, hey, if I was coming in for a traffic ticket, I would be a nervous wreck, because you hold the next decision in your hands and we were trying to get them to, because they're working with us, to buy in. When someone that we're working with extreme mental health comes in, imagine what that feeling is when you're behind that big desk with the robe on and they're walking in knowing that you hold that piece in their hands. It's the same concept here that we try to talk about when we train CIT officers. When you arrive on scene, just remember that feeling that any person has, because law enforcement holds that power. And how can we make sure that we can kind of de-escalate that piece and work together? So it's just that understanding that in many situations, there's a very anxiety producing piece to every person who has to deal and maybe not have control of the situation. So the goal is, by working together, that there's ability to share that responsibility of de-escalating that situation. And not everything that we go on needs to be de-escalated. I just want to say, many a times it's providing resources. We went just yesterday out on a follow-up, and all we did was listen to the family, have a conversation about the first interaction and like where we could be more helpful the next time. They weren't in crisis. We just went for a follow-up. So not everything we do is crisis driven, but a lot of it is just follow-up support. So I know we're about out of time.
Well, absolutely fascinating. It just seems like there's so much caring involved about the community. And the other piece that I'm really hearing is also about that follow-up. The way that you're approaching it is exactly the overall goal, care that feels like care, right? And so, let's go to the roundtable if we could. We're going to go to Carrie Slatton Hodges, who is with the National Association of State Mental Health Program Directors as a Senior Behavioral Health Advisor. Carrie is also the former State Mental Health Commissioner for the state of Oklahoma, and did excellent work in Oklahoma related to technology and crisis response. Carrie, can you give us your thoughts and reflections on the featured presentation?
Yes, thank you, Megan. And I would say what a wonderful presentation and what a wonderful program. And I do think that one of the things that, as Megan mentioned, that carries through is the incredible caring on both of your parts and how you really bring that to this program. And it's so wonderful to see. And I think we have to think about, as we're building out a crisis continuum of care across our nation, and as law enforcement is looking at mental health and addiction issues from a different lens, this is all a work in progress. So when you mention the length of time that it takes mobile crisis to respond, and therefore there may be a police interaction prior to mobile crisis or waiting for mobile crisis, then obviously that lends itself to everybody needing to be knowledgeable and empathetic and knowing about resources and handling those situations in the best manner. As Megan mentioned, one of the goals is by 2025 to have access to mobile crisis in a means that is rapid and on the spot, but we are a long way from that across our nation. So we're continuing to build, law enforcement is continuing to build community programs and understanding, and the crisis continuum is continuing to layer in additional mobile crisis and more receiving centers, et cetera. And so I think what we have to think about is we need to work together to share our resources, extend our resources to make certain that persons who have mental health and addiction issues are able to get the resources that they need and the treatment and care that they need. One of the things I think that lends itself so much in the debate, which there hasn't been a debate about co-response or law enforcement response, is the fact that still across our nation, there is a high percentage of people who have substance use disorder and who have mental health issues that get moved along the criminal justice route as opposed to into care and treatment. And the numbers are still there. As we see across our nation, the number of persons involved in our forensic mental health system as a result of receiving charges and being so ill that they're not competent teaches us that we still have such a long way to go to get people into care and treatment, as opposed to going the direction of the criminal justice system. And that is what makes the push for mobile crisis teams so strong, is that hoping that we can reduce arrests and reduce the number of persons going into the criminal justice system. So there is kind of a push-pull, and the work that you're doing in your community is such a great example of having that same mindset of wanting to get people to resources and wanting to get them care and treatment as opposed to going the criminal justice route. And in reality, there should be no wrong door for persons who need access to care and treatment, whether that be that law enforcement is first on the scene or law enforcement comes with a co-responder, or where mobile crisis is first on the scene. There should be no wrong door to getting that care and treatment. And I still, stigma still plays such a role in that if you were a person having a heart attack, and regardless of whether it was an ambulance that responded first or law enforcement that responded first or fire department, you're not going to see a situation where people are going to run warrant checks first before getting that person into care and treatment. They're going to immediately think about how do we get the immediate need that this person has for healthcare taken care of. And that's going to be the priority over everything else. And we still have a ways to go to get there. And I love your safe space where persons can come in, and what is first and foremost is how I can link you to care. But I do have to say there are many communities across the nation that the thought of interacting with law enforcement or calling 911 is very scary, and that the outcome is perceived to more likely than not be a negative outcome. And that's why we have to have options like 988 and mobile crisis response, where that fear of law enforcement still exists. The community policing model of really engaging with their community and being seen as a helper and a connector to resources is so important. And I just applaud the work that you're doing of really trying to turn the model back to a community policing model. And I think in the long run, it's just going to take all of us to be able to work from the law enforcement side and the mental health side to get persons the care and treatment that they need. And I think in the long run, what we will be asking ourselves is not, should it be a law enforcement response? Should it be a co-response? Or should it be a mental health response? But in the long run, we'll be asking ourselves, when should it be one or the other? That there are times when perhaps a law enforcement response is needed, and we need to define and be clear about when that may be. There may be times when a co-responder model is the appropriate response. In particular, you were saying in a community maybe that doesn't have mobile crisis resources or doesn't have timely mobile crisis resources, and we know that law enforcement is likely to be first on the scene, well, then absolutely you would want a mental health professional along with that law enforcement so that they can tag team and get that person to the right resources. But when we have mobile crisis response in a timely manner that can prevent law enforcement from needing to respond to the scene, then that is perfect as well. So I think what we really need to look at is, when are the different models appropriate, in what situations, and when they are responding, regardless of whether it is a mental health professional, a law enforcement officer, or a co-response model, that there are persons who are going to the scene with the goal of linking that person to care and treatment and making sure that we're diverting away from the criminal justice system and treating this like the medical situation that it is, that a person needs care and treatment immediately. I also just wanted to comment for a moment on what you were talking about in terms of law enforcement and the needs that they have. And, you know, one of the things that we know when you look at suicide rates, that law enforcement officers are more likely to be male and within an age range that is high risk for males in suicide, and that have access to lethal means. And so law enforcement and first responders are also a high risk category of individuals for needing care and for needing crisis intervention services. And so then when you add in the vicarious trauma that is happening on a daily basis with law enforcement, we truly have to look at law enforcement as part of not only the solution, but part of our community and part of the group of people who does need support and linkage to care when appropriate. I'll just point out one thing that was done in Oklahoma. all law enforcement officers in Oklahoma have a tablet that links them with a mental health professional immediately. But there's also a button on that tablet where the law enforcement officer themselves at any point in time can hit a button and talk to a mental health professional that is outside of their area to talk about what their day's been like, family stress, community stress, because we know that that is a group of individuals that's part of our community and needs support like all of us do at any given time. So thank you so much for allowing me to have a comment. Thank you both for being here and sharing the wonderful model and work that you're doing. Megan?
Harry, thank you so much. And thank you for bringing in that broader question of, you know, when, what situation. It really seems to speak to that communities have different needs or different setups or are in different places to be able to implement along that continuum. So let's go to Samantha, and I'm going to try to pronounce your last name. Give me the chance. Is it Benecki?
Close, very close. It's Benecki. It's my married name. I messed it up for the first like 3 years of my marriage. I get it.
Yeah, helped us the same way. So Chief Program Officer from Dignity Best Practices, really thrilled you're here. Can you give us your perspective on this issue?
Yeah, I mean, I think the first thing to note is it is so complex. Crisis in general, the way that our systems currently operate. There's the ideal that we're working towards, there's the future, and then there's the current state of now. And so one of the things that I get to do in my role is I look at a lot of 911 call data. So when I'm working with a client or a jurisdiction, I go in and I look at their 911 calls. How many calls did you get this week? What were they like? And through that, one of the things that has become very apparent to me is there will always be some need for law enforcement in mental health crisis. Because currently, and maybe the future will prove me wrong, and that would be exciting, but we don't have the language for crisis. So if you look at 911 calls, if you look at the type of calls that co-response is responding to, they often present in a way that would be ruled out of diverting them to 988 or diverting them to a civilian-only model. They have things like immediacy. So somebody who is in crisis right now and is expressing the intent to act right now, we don't have the setup to send a clinician to that alone. We have to send somebody who's going to go quickly. And so if we're looking at law enforcement is going to be the option, is going to be the one that is responding, adding a clinician actually is adding support. It's adding that care, that understanding, that level of engagement, and bringing that to the call in the moment. Other calls that I see all the time are individuals who are experiencing psychosis or delusion. Those are not words that the normal passerby has to explain what they're seeing. So instead, they see somebody who is behaving out of the norm and potentially has something that could be considered a weapon. And so when you look at 911 call data, when you get into these systems, it's going to take time, and it's going to take us educating the public on how do we communicate what we're seeing and being mindful that our language can have bias. Because the way that it's presenting, the way that a lot of this comes across the table for dispatchers, call takers, is really limiting in what they're able to do. And so kind of understanding and having the capacity of like, this is the reality we're in. And so then looking at co-response as this is a program that gets clinicians and officers to these, gray areas quickly, and allows there to be both. It allows there to be a moment of care, clinical understanding, assessment, engagement. And it also understands that these calls as they present would not be diverted. They would not be handed to a civilian-only team. So this is like one of the things that I'm always really excited about, is that there's the possibility and the option for this kind of engagement. The other one is I share quite often, I have a father who has a type of dementia called Lewy body dementia, and it has hallucinations. And so my father personally does not know who to call. So some days he will call 988 and describe essentially a panic attack, and they think it's a heart attack and it's very complicated. And then other days he will call 911 thinking that he is being pursued by somebody. And so when we talk about systems that talk to each other, when we talk about needing there to be the capacity for both, I live in that. I live in the example of there are times where, no, my dad actually probably needs EMS or maybe even law enforcement or somebody to help right now. And then there are other times where, you know, I wish that I could just mute my father's phone, but that aside from that, that he really just needs that care, that support, somebody to sit with him, somebody to tell him like what you're experiencing is real and valid, and it not to be something that is deemed as a emergency or engaging law enforcement. But what I need as a person in this, a family member in this situation is I need systems to talk to each other. I need the 911 and 988 to be able to have the capacity to do exactly what was being said of what is the right fit for this moment and who needs it. And so really understanding and honoring that this is a complex space, and really the most we can ask of people is doing the best they can and doing it with good intention and understanding where you fit in it. And so, you know, I'm really excited about Anne Arundel County. I've gotten to work in a lot of Maryland spaces, and so I know some of the challenges and some of the complexities of having to go to the ER, having to be, you know, evaluated. But also by bringing that clinician in, they're taking that opportunity to say, what is possible as assessment and intervention before that point. And so really honoring that experience. So, you know, really quick, I know that there's so much more to learn, but essentially it's just, we have to all honor that this is a complicated and complex space, and nothing is going to be clean cut and pretty. And yes, there are so many calls that do not need law enforcement, that are nonviolent, that are not emergency. And there are also so many calls that come into 911 systems that in current realities would not be available for diversion. So then can we provide help in the most effective way possible?
Absolutely. Samantha, thank you. Carrie, thank you. Great questions. One of the things I love about the Crisis Jam is it gets everybody thinking, and the understanding that things can be very different in different places and different situations. We do want to just move to Dr. Mike Riddle on improving access to crisis care and law enforcement partnership. Mike, can you talk a little bit about what this picture is?
Sure. So actually, this is a picture I took myself. I am the Associate Chief Medical Officer for RI, but also the assigned medical director for our flagship location in Peoria, Arizona. And one night on my way home, I came outside and saw a line of officer vehicles outside of our police entrance. So I thought I would take a shot, and it's become viral around RI since then. So what it does is this really, I think, portrays our strong relationship that we have with law enforcement. And so in this discussion with me, I do want to applaud the roundtable discussion. I think there were some excellent points. I think that a lot of folks in the mental health community are very sensitive about law enforcement, and hey, it's for good reason. So, I mean, if you look at the evidence in the literature, historically, 1 in 4 fatal police encounters involve someone with severe mental illness. Not okay. And historically, 1 in 5 of all jail and prison inmates has severe mental illness. Again, not okay. And so I think our goal in each of our communities, like we keep saying, is to continue to advance, evolve, learn, try and predict. But today, unfortunately, it still remains a little bit unpredictable, and there is a very significant gray zone. And that's why I'm not gonna hate on a co-response model. I'm in Maricopa County in Phoenix, Arizona, where I see all three models. I see crisis mobile team only, I see law enforcement only, and I see co-responder units, and they all kind of do what they do well. And so I think it's important to kind of respect where we are today, and that we are growing and we are improving and we are doing our best to divert folks who are challenged with mental health symptoms and not placing them in jail, not booking them on charges, not just kind of compounding the problems that they're having in their life, and trying to help engage them and get them into treatment so that they can advance and meet their own goals. And what I see the crisis response, or the crisis receiving center, I'm sorry, their involvement of that truly is to be a champion of spreading the message, to be an educator, to offer a no wrong door solution to folks right at the beginning of the crisis, whether we receive a mobile drop off from a mobile crisis team, law enforcement, family, it just doesn't matter to us. But when we talk about law enforcement, we do a couple things in particular that are very purposeful, one of which is portrayed in this image. So we place our law enforcement drop off in a strategic area on our campus that's very easy to see, and we make access for law enforcement officers rapid and simple. It's a 3-minute drop off, because we know that if a drop-off time at Peoria takes a really long time, officers will choose jail, officers will choose ED, and we would say that neither of those models have as good a results as if you have a complete mental health response. You're not bringing in other things, but that's not always the answer. And that's the thing that I'll admit. There are folks that need to go to the emergency department. And in fact, we send 5% or so folks who are brought to us from law enforcement to the emergency room for additional medical stabilization. So that there's just no one size fits all model. It's always going to be kind of this diverse model where we're learning how to use it better over time. And then the other thing that the crisis response centers really do for the communities is we engage with law enforcement all the time. I've had one-on-one conversations with law enforcement officers that just want to pick my brain about something that happened to them in the community, and not understanding our response, or not understanding why something wasn't criminal. And I'll just sit and have a long conversation with them. I hope they leave that with more information and an altered perception. We also, hold monthly community meetings where law enforcement officers come, they engage with us. We have multiple avenues for feedback to make sure that law enforcement officers are having a good experience using the crisis receiving centers, and our guests that we're serving at our center are having a good experience using our services, so that we also ourselves are constantly learning, but making sure with law enforcement that we are the drop-off preference and not emergency rooms and jails, so that we can start things and then make those decisions quickly and get folks where they need to be if we need to pivot.
Dr. Riddle, thank you. I'm loving the theme that I'm hearing about the underlying goals of what we're trying to do: engagement, empathy, follow-up. So thank you for your perspective. Thank you for sharing. Really appreciate it.
Thank you.
Great. We're now going to move. As I said, the 988 grantee meeting is happening in Chicago, so SAMHSA is there. They will be here next week. We're now going to move to the NASHBID spot with Carrie Slatton-Hodges, who is also on our roundtable. Thanks, Carrie. Go ahead.
So I want to talk a minute today about how two emerging and developing models can work together. And that is, as you know, we're all building our crisis continuums of care, whether it's in our communities, across our state, and then, of course, across our nation. The other model that is emerging across our nation that it's really transformative is CCBHC, or Comprehensive Community Behavioral Health Clinics. And it's amazing the overlap and the commonality between these two models. CCDHCs require a community needs assessment of what gaps exist. They require that crisis services, having a number to call, having people to go out, and a means to treat are part of that continuum, just like our crisis systems are. And the piece about community behavioral health clinics that is so incredibly important is that the way the finance model works for these systems allows the provider to develop a 24/7 capable system. So since the payments are based upon a cost report, you can build in 24-hour accessibility into those costs, as opposed to operating on a fee-for-service type of model that doesn't cover the cost of having the capacity available 24/7. In addition, both really point out the incredible importance of having persons with lived experience as part of the model. So when you look at these two developing systems across our nation, they are a perfect fit for working together hand in hand, whether that's from a state perspective of how to finance and grow the crisis continuum, or from a provider perspective of how am I able to support crisis work within my community and within my state. So with that, I wanted to say that NASHBID is working closely and partnering with National Council to provide technical assistance and resources around how these two systems can interact and help states develop their comprehensive crisis system. When you go to the National Council webpage, there is a state technical assistance center that can help states look at that overall picture and how to blend the two together and how to plan and manage that. And then there are resources for providers who are CCDHCs as to how to develop their crisis continuum in a way that meets the requirements for CCDHC, but really the needs of their community. So there's a lot of great work going on around this space. We would love to help providers and states with that work as we continue to build our crisis continuum of cares across the state. And we see what a wonderful mesh and blend it will be as you also are developing your CCDHC systems across the state. So thank you, Megan.
Thank you so much, Carrie, and thank you for your work on this effort. We are now going to move to Joanna Rosen, who is with the American Foundation for Suicide Prevention. Joanna.
Thank you, Megan. It's great to be here with everybody. Sarah is out this week, so it's just me. But just a quick update in terms of the federal budget for FY25. Congress is really getting to work to try to bring us back to a somewhat regular order and not rely on CRs to fund the government over the next fiscal year. So House deadlines for member submissions for FY25 to the committee are approaching, with member request deadline originally for today, but that has been extended to Friday this week, we've just heard. So that's good, and it'll give House members a little more time to get their submissions in a very short-term turnaround. The announcement was made last week on Thursday. So really quick deadlines for them, and this will give them a little more leeway. Senate deadlines begin a week from today, and those deadlines vary by committee, with the Labor, Health, and Human Services due May 14th. So looking forward to seeing what gets included in FY25, and we will keep you all updated as we move forward. Thank you.
Thank you, Joanna. We are now going to move to Stephanie Hepburn for Crisis Talk. Stephanie, are you on?
I am. Thanks, Megan. So I'd like to introduce Sam Dorison, who's Reflex AI's CEO and co-founder. Last week, I was on Reflex AI's free home team app, and I chatted with Blake, who is an AI simulator persona. And the app is designed to help military veterans and family members practice having tough conversations about mental health and suicide with their peers. Sam, you told me that these conversations are similar to flight simulators for pilots. Can you explain what that means?
Yeah, it's really great to be here with everyone, and just this whole conversation is incredible. What we mean by that is there's been a lot of talk about AI and how it can be used in mental health. And the intuition from the flight simulator is none of us want to get on a plane where the AI is flying the plane, but we're very happy to get on the plane where the pilot has been trained using an AI flight simulator. So that's what we mean by this. We've really been focused on how do we build hyper-realistic simulations for crisis lines, behavioral health centers, and others to support as a key part of training their staff and volunteers, while knowing that at the end of the day, you need a person on the phone to pick up those calls.
Sam, how are crisis lines using the tech? Can you explain that a little bit? I know it started at the Trevor Project, so if you could just give a little bit of background and what's happening with crisis lines at present.
Yeah, we're seeing a good number of crisis line partners incorporating these simulations into their existing training. So they have the content components of their training, they have discussion groups, call centers do it differently. But one of the common pain points that we heard, and Stephanie, we talked about this a lot, is that the manual one-on-one role plays that are really critical to demonstrating your skills, but also solidifying them and deepening them as you're building confidence, it's really, really manual. And being able to do a good chunk of that with hyper-realistic simulations is fantastic. And they also have immediate feedback after you do the simulation on your empathy skills, right? Did you conduct an effective risk assessment? Did you ask open-ended questions? Did you follow protocol? So that trainers really have this as a tool of as a big part of training, along with everything else that they're doing so well already.
And you said that trainees can retake it. So let's say they don't feel like the scores reflected and they want to learn more, they can retake it. Is that right?
Yeah, I started in this space as a crisis responder, and I remember the first time I had to ask about suicide risk, I couldn't get the question out, right, in training. And then the second time, I think I said something like, you're not thinking of killing yourself, right? Which is not an effective question, right? It's not neutral. It's certainly judgmental. So being able to do the simulations a few times, you get better at it as you go. You get more confident. You practice with different personas, so that by the time you're in final role plays with a human-led, with a trainer, you've ironed out a lot of those skills, and the trainers don't have to spend their time providing the same sort of feedback repeatedly, right, on those kind of core skills.
Well, thank you so much, Sam. I'm going to pass it back to you, Megan.
Yeah.
Fantastic. Thank you. Sam, I'm wondering if you can develop something for parenting in the same way. That would be very helpful to a lot of us.
Yeah.
So
we actually, I know maybe you were joking. I will say we work with Partnership to End Addiction in New York that has a parent peer support line. And so we actually work with them already. I'll put our email in the chat. We've been doing this since 2019, started the Trevor Project. So would love to follow up with folks. I know the agenda is super tight.
that's wonderful. I mean, to kind of have that trial run before you're in the situation for real, and getting kind of used to and stepping up to what needs to happen. That's brilliant. Thank you. Thank you. All right. And thank you, Stephanie, for that article. Fantastic. And thanks for your questions. Just coming next week, we have Wendy Bailey, who is the State Mental Health Commissioner for Mississippi, to talk about outreach to communities of color and marginalized people. She'll talk about the CROP initiative, which is faith-based, just a wonderful initiative we've been sharing about. And the week after that, we have helping frequent callers to helplines, Dr. Brian Mashara. Just delighted that he will be here with us in 2 weeks. And so just want to thank everybody for being on. Thank you, Jennifer Corbin. Thank you, Lieutenant Steve Thomas, for your excellent, thoughtful presentation and enlightening us in all the kinds of different perspectives we can be looking at and what communities can be and what we really need to be thinking about. Thank you to the roundtable, Carrie Slatton Hodges and Samantha Benecki, and just Dr. Mike Riddle, Thank you, Joanna Rosen. Thank you, everybody, for being on, and Sam Dorson, Stephanie Hepburn. Just excellent perspectives and all of the thoughtful things in the chat. It seems like just from the chat, we could have a whole other crisis jam to talk about some of the issues discussed today. So thank you. Have a wonderful rest of your week.